So today there will be two live demonstrations of complex PCI.
It's my pleasure to show the patient's information. Patient, 80 years old, mate, chest pain for 10 days with fastest not positive cardiac biomarker, low eGFR, normal ECG, and UCG, lab 2, 3, AVF, V, 3 to 2, 6 is ST7 depression. We diagnose this patient is non-STEMI, CHD, and ST. This is baseline angiographic result. The middle segment of RCA is a serious nasal lesion accompanied with calcified lesion, and the distal lesion is borderline. We see the cranial LAO showed the proximal and the middle segment of AAD is serious nasal lesion accompanied moderate and serious calcified lesion. And we see the distal AAD is borderline lesion. This is IO, the CAG result. Left change, we use a 3 stand to solve the proximal and middle segment of the RCA. Use the 3 stand.
As you can see, the patient is high-risk level patient and with the right dominant, and we have performed the previous PCI and 3 DZS to cover the ICA disease. And today, can you see our today's angiographic log count artery? You can see very clearly the previous stent in the proximal segment of the circ, and also for the distal circ with the first obtuse marginal is also a Medina 0112 buccal lesion. But today our tag lesion, please switch to the cranial view. It's LAO cranial view very clearly. It's diffuse down lesion just involved from the proximal LAD to extended to the distal LAD. And the prox segment of IVD, you can see very severe, heavy calcified lesion, and also with the angulation more than 45 degrees. This is our today's angiography. Because our TAC lesion is LAD, severe calcified lesion, we perform the IVUS. For the severe calcified lesion group, the IVUS guidance PCI has the privilege when compared with the angio-guided PCI. So IVUS casts very smoothly, just we send to the distal segment of LAD.
Let me show the IVUS imaging. The first one, we check IVUS from the distal LAD to left main. And here we can see the distal LAD vessel is normal. The vessel diameter about 2.6 millimeter. And here, this point is the distal landing zone. Then pull back, we can see eccentric plaque. Then go and pull back, we can see the bifurcation. This is the diagonal, small diagonal, and the small septal. And the distal landing zone near the bifurcation about 6 millimeter. Then go and pull back, this is the distal LAD. And the distal LAD vessel diameter about 3.0 millimeter. And the plaque is an attenuation plaque. Then go and pull back, we can see calcified plaque, but the calcification angle is not more than 180 degrees. Here we can see another bifurcation. Here we can see the diagonal 2 we are drawing LAD. And here this is the LAD and the diagonal 2 bifurcation. And here the calcification angle is more than 270 degrees. And here the lumen is just 1.4 millimeter. This is the LAD and the diagonal 1 bifurcation. And here the proximal LAD and this point is the proximal landing zone. And here the lumen diameter is about 3.6 millimeter.
Then we use the syntactic score to evaluate the patient with the stratification. We see the syntactic score is very high, but the patient age is older and reluctant to accept cabbage. So we choose the PCI strategy for this patient.
I think from the IVUS imaging, Dr. Panto has interpreted very clearly. It's a very diffuse lesion from the proximal LAD to very distal LAD. But the severe calcification actually from the angio and also from the IVUS only located at the proximal to mid LAD. So according to the IVUS measurement, the proximal LAD, I think the significant lesion, the minimal lumen area diameter only 1.4, and also associated with a very superficial and a very awful circle superficial calcifications. The arc is more than 300 degrees. So Dr. Yue, for these typical severe calcification lung lesions, I think before you plan put a stent, prepare calcified modification is very important. For this lesion, what's your strategy? You will use only cutting balloon, NC balloon to the predilation, or will use rotablation, or even you will use IVL treatment?
Okay, Chief, just according to the IVUS result, we can calculate the IVUS calcium score more than 2. And just from the Steven calcified PCI format, I think we need to use the rotational atherectomy or the IVL to preparation this lesion, just to acquire the very good stent expandation. I agree with you. Just according to the IVUS calculation, we can see the minimal diameter for the severe calcified lesion is less than 1.5 millimeters. So our strategy, we decide to perform the rotor first, to perform the modified the calcium plaque. Then we check IVUS again, just to evaluate whether we can dilate the calcified lesion.
Yeah, I fully agree with your options for these particular calcified lesions. So rotablation or 1.5 burr first, then check the IVUS and then make a decision. So go ahead.
Okay,
Dr. Yu.
Okay, Chief. So we have just delivered the 1.5 burr just nearby in the proximal LAD. Initially, burr size, we use the 1.5 millimeters and want to use the high-speed rotablation.
160.
Okay. We just gently touch the lesion.
The speed is
10.
Yeah.
160,000 RPM.
15.
15. Okay.
The speed is maintained. The patient is stable and the hemodynamic is stable without any ECG change.
Okay, second round.
160,000.
Yeah. There is some
5
resistance.
seconds.
Yeah.
Okay.
Thank you.
Here is our target, very severe and circle superficial calcified lesions.
15 seconds.
15 seconds.
Okay. Still some resistance. Maybe still we need the third round.
Yes, third round.
Okay, the third round is ready.
Yeah, ready.
160,000. 5 seconds. 10 seconds.
Yeah.
Okay.
Nice.
Yeah.
Okay.
Pass. Yeah.
The hemodynamic is stable without any ECG change. Do you need any tests to check the flow?
Yeah. Okay, Chief. Okay, flow is
Yeah,
good.
flow is good.
Yeah.
Good. I think after 3 round rotablation, we have successfully closed the significant lesion of the proximal ID. Do you still need? Do you think we still need the 1 or 2 round rotablation?
Just I just want polish. I just want to see. Okay, yeah, we can use the 1.5 polish. Yeah. Just because the angulation for the second, just at the side of the second diagonal, more than 45. I can see small dissections. Okay. So I just want to check IVUS to see whether we have the wire bias. Okay. If the wire just bias to the normal vessel wall, maybe we should stop burr size escalation. Okay. Maybe IVL will be safe. Okay, 14万。这样14万。好。Okay, we use the low speed polishing.
Seconds.
Yeah.
Yeah.
No speed deceleration, right? Yeah. Okay, very smooth.
Yeah.
15 seconds.
Okay, I think we can finish, Chief.
Yeah.
Yeah.
Very nice.
Before retrieve the burr, I will test first. Yeah, okay, flow is good. Yeah.
Without complication.
The Chief, we just use the microcaster to retrieve the wire, to exchange the wire.
For these scenarios, considering very long lesions, and what do you think you will use only a workhorse wire or you will use some stiffer support wire?
Okay, support may be better because after all, it's the long lesion and with the angulation. Extra support wire, please.
Extra support. Considering it's elderly patient, 80-year-old gentleman, and also the EGFR only 60.
60, yeah.
So it's I think it's CKD 2 to 3 stage. So we should save the contrast medians.
Yeah.
Actually,
So
support.
this is why we choose
Why?
the IVUS guided, not
Yeah,
the
yeah.
OCT guided.
Yeah, that's a very important point. Dr. Pan, you can interpret the IVUS image.
This vessel is about 2.75. Here you can see eccentric plaque. I would say tooth distal. Distal LED here vessel is more than 3.0 millimeter.
Very eccentric fiber plaque, just at the
Yeah.
mid LED. Yeah.
This segment is balloon dilatable lesion. Maybe NC balloon preparation is enough.
Yeah. Is there any dissection? This is a site
Maybe
just between the septal and the second diagonal. Yeah.
We can also see the reverberation.
Yeah.
3 layers. Yeah.
yeah.
Yeah. Yeah. There is a broken segment at the 9 o'clock.
Yeah.
Yeah.
The shifts, we still have the more than 180
This is
degrees
diagonal one.
continuous calcium, superficial calcium.
Yeah, you can see
Yeah.
here there is
Yeah.
some small broken segment.
Yeah. We can also see the minor crack. But for the proximal segment, because the vessel diameter is big, maybe 1.5 Br is not enough.
The lumen diameter is more large, more than
me some-
1.8 millimeter.
Give me some ATP, please.
Okay. So, but still, I think there is a superficial calcification. The broken crack is not enough.
Yeah.
So maybe we still need IVR treatment,
yeah.
further IVR treatment,
Okay.
get a better plaque modification before we put the stent.
Yeah, we agree. So Dr. Fan just calculated the diameter of the vessel diameter.
3.0.
0.
So
Okay.
just the reference vessel size.
Yeah.
3.0, okay.
3.0.
So next step we'll do the IVR treatment with a 3.0 shockwave balloon. Okay. So it's a typical, I think, combined treatment with a rotablation and IVR treatment for this severe calcification before we put the stent.
Okay, Chief, we just deliver the balloon.
Okay.
Seems okay.
Yeah. Please
Okay.
give some tests.
Okay, test please. Test please.
So actually we have started shook with this IVR device. The first round, we up to the atmosphere to 4.
Yeah, 4. Yeah. Okay, going up to 6.
6.
Now it's up to second round. We're up to 6 atmosphere, fully inflation the shockwave balloon.
We can see the balloon expand good. Well,
Yeah,
okay.
I think the balloon shape is a fully expansion. Yeah, which means I think the superficial calcification has been fully shooked.
Let's see.
From the ECG monitor, I think when
EKG...
AVR, the ST segment a retro elevation. Yeah.
Sorry. Okay, please take a picture. Go. Okay, seems very good.
Yeah, I think we lost a very small, the third diagonal.
Third diagonal,
yeah. But the first diagonal and the second and the first diagonal is still there. Yeah.
Yeah. Maybe some spasm for the vessels.
Yeah.
All the vessels.
Yeah. And also you can see the ST elevation at the 1 AVR is better resolved. Yeah. Just to mention, I think this may be the spasm after rotablation and the IVR treatment.
Yeah. Natural, please. Again.
Natural again. Yeah.
Natural again. Okay. Okay. We'll take picture for you. Okay.
Sure.
Okay. Better than before.
It's large spasm. Yeah.
So, Chief, I think next for the distal segment, we need the NC balloon to prepare the lesion.
Sure.
Okay. Give me 2.5 NC balloon.
2.5 NC balloon.
2.
Yeah.
Fine.
2.5 NC balloon. So this segment is just balloon dilatable. We just use the nominal pressure. Yeah, it's 2.5 NC balloon.
What's the balloon size? 2.5 by 15?
By 15, yeah.
Okay.
15 yes. So till now, patient's blood pressure is okay. No ECG changes. Okay, I'll give some natural to check IVUS again.
Distal LED. No more. 2.5 millimeter.
And maybe vessel still have this spasm.
Yeah, I think so.
Yeah. You can see minor dissections.
Yeah.
Yeah.
The section at the 11
Here,
o'clock.
dissection,
Yeah.
medial dissection.
The vessel size is up to 3 millimeter.
The chief for the distal segment, I think 2.5 stent DGS.
Yeah, I
Okay.
think it's enough. Yeah.
Okay. Prepare 2.5 by 38. Yeah.
According to the baseline IVUS measurement, the total length is 64.
Yeah.
So maybe 238 stent is enough. Overlap 4 millimeter. Yeah.
Okay.
The first one is 2.5. Second one is 3.0.
3.0.
Yeah. Both lengths is 38 millimeter.
Okay. So chief, I think here is okay. Just the
Yeah,
last
I
diagonal.
think so. Yeah.
Okay, just inflate. Inflate to 6, 8.
What's the nominal pressure?
10.
10.
Yeah.
Long
10.
time inflation, at least
Okay.
15 seconds.
15 seconds.
Long
Okay.
stent, long time inflation can achieve the stent full expansion.
Okay.
It's very important. We still use a stent balloon to do the post-dilation up to 12 atmosphere.
Okay.
Okay, take a picture, please. Okay.
Yeah, it's good.
Yeah, to diagnose seems okay.
Yes.
So chief, do we need to protect to diagnose? Seems okay.
I think it's okay.
Okay. Okay, thank you. Distal segment flow is good.
Good.
Oh,
The first
okay.
diagonal flow is only maybe a TIMI1. Yeah.
TIMI1,
We
yeah.
should give some nitro.
Nitro, give some.
And-
Okay. Okay, after the 2.5 post dilation, I will give a picture.
Oh, nice.
Yeah, very good.
Nice.
3.0. The two diagonals is good. Okay.
Yeah.
Yeah.
Still there. The first and the second and the fourth diagonal.
Yeah.
Good.
So chief, we will check the IVUS for.
Okay, go ahead. Please do the analysis for the IVUS image.
Okay.
To tell us if we have achieved the optimal ultimate criteria.
So Dr. Pan, please. Yeah. Yeah, it's a distal segment, right?
Yeah.
This is a minimal stent area.
Okay.
Before it's a small stent, 2.5. Maybe I think 5.0 is not suitable for this scenario. I think stent expansion larger than 0.9 is suitable for this scenario.
Yes, the distal reference vessel is just 4.5 millimeter.
4.5.
So the expansion index is more than 0.9.
Okay.
0.9. Okay.
Okay.
The distal is okay, right?
Yeah, and the proximal is okay too, no dissection.
Yeah.
And the plaque burden is not more than 50.
Oh,
Yeah,
So
can you
the-
measure it?
Yeah,
The plaque burden. It's very
Yeah.
important. It's a site because it's a proximal ID. Yeah.
yeah. So the
Or-
result is consistent ultimate trial.
okay.
Less than 50%.
Yeah, I think less than. Must be less than. Okay. 41.
Yeah,
41.
I
Yeah.
think. So, Dr. Yu, I think according to the IVUS analysis, we have achieved the ultimate optimal stent expansion.
Okay.
So it's
So we can finish the case.
yeah, sure. So I think, Dr. Yu, can you give some summary for this case?
For the big severe calcified lesions, lesion preparation seems very important before the DGS implantation. So that's why for today's case, we use the rotor just modified to easily let the IVL balloon to pass through. So we use the 1.5 just to let the IVL balloon. IVL seems better, seems safe, much more safer when compared with the big size balloon rotablation. So you can see the final results just meet the 3 criteria of the ultimate criteria. I think we can finish the case. Thank you all. Thank you very much.